Now today we're talking about the oral hypoglycemic agents for diabetes and which drug to choose and why to choose. Now the question is very simple. Most of the time we have to choose depending on the patient's HbA1c or patient's sugar values. What is their fasting blood sugar? What is their postprandial sugar? So on these values, we have to choose what drug to use. If the sugars are very much high, suppose if the fasting is around 200, or if the postprandial is around 300, 380, so these values are very high. So we need a high efficacy medicine which can reduce this much of sugar. If we give a low medicine drug, this will not cause that much of sugar control. So which are the high efficacy drugs? Now the high efficacy drugs are the sulfonylureas like glimepiride, gliclazide, insulin. These are high efficacy drugs. Whereas the other drugs like gliptins, voglibose, metformin, SGLT2 inhibitors, these are not very high efficacy drugs, but they will cause HbA1c reduction of up to zero point 0.8 to 1.2 and zero point 0.8 to 1.2. But these glimepiride, gliclazide, insulin can cause HbA1c reduction of up to 4 very easily. So if you want to control the blood sugar very fast, if the sugars are very high, then go ahead with the sulfonylurea or insulin. The second component that comes into the picture is what about weight? What about weight variability? Or what about if the patient is obese or thin built or what? If you don't want any weight effect on the patient, we can select gliptins or voglibose. These will not cause weight gain or weight loss. If you are worried about weight gain, then preferably glimepiride insulin should not be given, or they should be given with some drug which can cause weight loss. For weight loss, metformin SGLT2 inhibitors can cause weight loss. So these medicines can be given. When it comes to hypoglycemia, glimepiride, gliclazide, insulin, these medicines can cause hypoglycemia and they have very prominent action on the sugars. So if there is one patient who is elderly, who had recurrent episodes of hyperglycemia, then in those cases, this glimepiride, gliclazide, insulin should be used very, very carefully and because they can very marked cause hypoglycemia. Whereas this metformin, gliptins, voglibose, pioglitazone, SGLT2 inhibitors, they actually don't cause hypoglycemia on their own, but if these are combined with some other medicines or if they are combined with each other, then these medicine can cause hypoglycemia. Now, if the patient has reduced EF, if the patient has heart failure with reduced ejection fraction, if the patient has proteinuria, so whenever there is proteinuria, whenever there is protein in the urine, these patients are supposed to progress or a product to CKD, chronic kidney disease. So if these patients have diabetes, then we can give one drug which can actually improve the mortality, morbidity in these patients, and which can also improve the renal outcome, which can reduce the proteinuria in these patients. And that drug is SGLT2 inhibitors. That can be empagliflozin or that can be dapagliflozin. These medicines can give cardiac benefit as well as renal benefit and benefit in mortality, morbidity related to the cardiac outcome. So SGLT2 inhibitors should be always chosen, and this is one of the most important pillar of heart failure. We have four pillars of heart failure. Among one is these uh, SGLT2 inhibitors. Regarding efficacy, I already told for maximum is sulfonylureas. They are extensively used. Like glimepiride is one of the most commonly used drug, gliclazide, and insulin. Obviously, that can be short acting, ultra short acting, or long acting. And low efficacy drugs are gliptins, SGLT2 inhibitors, voglibose, metformin. So when they are combined with each other, the efficacy or the sugar control given can be much better so that these medicines need to be combined so that number of medicines or the number of drug burden pills can be reduced, whereas even a single pill of glimepiride can give us a very good sugar control. So these were different points which should be always remembered, and on these basis we can give the sugar control, sugar medicines. Apart from that, we have to also look for renal parameters, and we have to modify the dosage as per the creatinine clearance. Or like glimepiride, gliclazide, insulin, they can cause marked hypoglycemia, so they should be avoided in elderly patients. And in elderly patients, slightly higher sugar value should be accepted. CKD patients or those patients who have creatinine more than 1.5, they have higher incidence of hypoglycemia. So glimepiride, gliclazide, insulin should be avoided. If the patient has acidemia, then patients with liver failure, hepatic failure, respiratory failure, they should be avoided with metformin because this potential the lactic acidemia. So apart from these points, we need to know the differentiating points or the special points of each and every drug so that we can avoid that drug in particular situation. For example, SGLT2 inhibitors, these drugs very commonly cause hypoglycemia. Very commonly cause UTI. The SGLT2 inhibitors, these drugs cause very commonly UTI. So if the patient is getting recurrent urinary tract infection, this drug should be avoided, or this drug should be first substituted with antibiotics. The urine infection should be cleared completely, and there may be after a few days, this can be again initiated to see the effect. The pioglitazone, basically, it is one of the excellent drug. It is one of the excellent insulin sensitizer, but it can increase the edema. It can increase the risk of congestive heart failure. So in that scenario, if the patient already has heart failure symptoms, if the patient already has recurrent hospitalization, or if the patient has edema, these pioglitazone should be avoided. So, depending on patient's characteristic features, the oral hypoglycemic drug should be chosen and should be started. So, I'll again come up with a more detailed video of this drug. Thank you.